It is just a profound honor for me today to be podcast interviewing Gerry Kugel, DMD, MS, Ph.D. from the Boston Center for Oral Health at drgeraldkugel.com, Associate Dean for Research and Professor of Prosthodontics and Operative Dentistry at Tufts University School of Dental Medicine with an expertise in clinical research and aesthetic dentistry. He is a reviewer for the New England Journal of Medicine, JADA, the Journal of Dental Materials, and the Journal of Dentistry. He's on the editorial board of the Journal of Cosmetic Dentistry, Compendium, and Inside Dentistry. He is a fellow in the American and International Colleges of Dentistry, as well as the Academy of General Dentistry and Academy of Dental Materials. Dr. Kugel is on the board of directors of the CRA Foundation and has his MS in Anatomy and Cellular Biology and his Ph.D. in Dental Materials. He received his Executive Certificate in Management from the MIT Sloan School of Business in 2009. He has published over 130 articles with over 300 abstracts in the field of restorative materials and techniques. He has given over 350 lectures both nationally and internationally. Dr. Kugel is part of a group practice, the Boston Center for Oral Health, located in Back Bay, Boston. He also created an amazing course for Dental Town, Sharpening Your Cementation Skills. My God, what are you going to do for an encore, dude? You have every accolade known to man.
Hey, well, look, I'm a busy guy, but life's short. I always say that. You never know. They're going to be throwing dirt on me someday, and at least I want to feel like I did something. So
I have seen you lecture back when you were a kid. I think I saw you. Were you lecturing as early? What year was your first lecture?
1986.
Yeah, and I got out of school in '87. I can remember when I was getting my Ph.D. and MAGD. I mean, you're just like the Albert Einstein of dentistry. So
I love you. I'll do these anytime you want, as long as I get complimented like that.
So I think the hardest thing you do is dental education. I mean, how do you take 100 kids off the street and 4 years later give them a license to go do root canals and crowns?
Well, it's funny. We actually have 200 up to about 205 now at Tufts. We have up the class size, and we have 30 international students. I mean, it's not easy given the fact that, remember when we were in school, we graduated, I was a couple of years ahead of you, but we didn't have digital dentistry. We didn't have CAD/CAM. We really didn't have implants to speak of. We didn't have to deal with occlusion courses like they do now. We should have, but we got very little on it. So I think the problem we have today, these poor kids come out of school having to learn so much in the same amount of time we had to. And, curriculums, ironically, or unfortunately, some of them haven't changed so much over the years. So, yeah, it's tough to teach a kid today. I teach in pre-clin. I'm probably one of the few associate deans for research. Maybe I'm wrong on this, but I think I teach 2 days dental students. I teach them in pre-clin. I run operative pre-clin. I also practice 2 days a week. So I do dentistry, and 2 days a week is fine with me. I teach at the university, and I teach dental students. So teaching kids, I get them when they don't know how to tie their shoes. I mean, fortunately, you get them once they can walk, I guess. So it is tough. I love it. It's the most fun thing I do in dentistry is teach young dentists. I feel like you are in this boat as well. We make an impact on people that we don't appreciate. And I'll tell you a story about why it's so important to be an educator who does it right, who teaches them the way it should be done as best we can. I gave a lecture at New Mexico Dental Society. Young guy who was a student here was now the president. And he introduces me, Dr. Supples. And Jeff goes, I want to introduce Dr. Kugel. Let me tell you a story about Dr. Kugel. The first procedure I did in the clinic was with him. And I was so nervous, and I was sweating, and I was scared. He said, do you remember what you did? I have no memory of any of this. He said, you pulled me out of the operatory. You told me, calm down, we're going to get through this. Let's get back in, we'll work together. He said, and I'll never forget that. I don't remember that. But the beauty is, as an educator, you make a difference in somebody's life, and you don't even know you made the difference. So my wife said to me one time, which would you give up? Would you give up practice, or would you give up teaching? And if any patients are listening, don't take this the wrong way. I would probably give up the practice if I could make the income in teaching that I make in my practice. So I love teaching. Tough today, though, you know that. With what's going on, corporate dentistry, the debt.
See, I was different when my wife said, which would you give up, teaching or dentistry? I gave up her. You know,
I can't. That could have been my third choice, but you heard of that one. Good man. But yeah, it's a tough time to be teaching. I mean, I think a lot's going on in dentistry, buddy. You know that. We're changing fast, and maybe not for the better, actually.
Well, you know, my first question, since you did the course on Dental Town, which is very well received, it's all 5-star rating, sharpening your cementation skills. One question everybody's having is, a major cause of failure of implants is excess cement when you cement it. How did we ever sell implant cements that if there was any excess, it caused the implant to fail? I mean, that's got to be, isn't that one of the bizarrest, strangest things in all of dentistry?
Well, I got to say, I'm going to practice with some very good dentists. And Dr. Weber, who's in my practice a day a week, he's chair of prosto here and ran the implant center at Harvard, and he's been doing implants since probably the 70s. He's doing screw-retained implant crowns. I mean, you know what? Because there's no cement when you screw that crown in. So I think what's happening with the cements is, one, it's lack of attention from dentist to detail. You got to get rid of that cement. I was with Nobel. We do some research with Nobel, and I was saying to them, you know, the problem you're seeing with the increased failures is also the fact that more dentists are doing implants today. I mean, you look at the numbers of the 96% success rate. You remember a lot of that data was collected when it was a select group doing implants. Plus, our cements are not so radio opaque anymore. So some of those cements that dentists are using, you look at a radiograph and it's hard to see the cement. So attention to detail. Cements may be a little tougher to clean up. Use a transparent cement if you choose it. It's even hard to see the cement sometimes. So I find myself doing more and more screw retained. I went from screw retained to cementable implants, and now I'm finding myself going back. And I was talking to some of the Nobel people. They're seeing that change as well. It is bizarre that that's where we're having our failures, that people aren't cleaning up cement. But I don't know about you, but I mean, I still practice, and I see cases come into my office where I'm getting chunks of cement from our implant crown. Plus the contour of some of those implant crowns make it tough to clean cement. So I see a swing back to screw retained. I know dentists don't like them, but the reality is I can retrieve it. If there's a problem, I get that baby out of there. Cutting off a cemented crown is not the easiest thing you do, particularly zirconia. You know, I have a love-hate with zirconia. Zirconia is a great material in many respects, except when you've got to cut it off. It's a nightmare.
But how do you have an ADA seal of approval or a major billion-dollar company actually saying this is with it on the label saying for cementation for dental implants?
I think it's pretty loose how you define that. I mean, you have to meet a certain opacity level, which is not too hard to meet. And I think prior to the implant issue, people didn't have the concern. If you leave a little cement behind, it's not a good thing. But around an implant, it's a catastrophe. I had a case where I was looking at crowns that were cemented in by somebody. I don't even know what cement he used, but I kept seeing shadows around the margins. I went in and he had cement under those margins. Now, I could see something on a radiograph, but I had to pay attention. So the cement you choose, some of these cements, again, are not as opaque as others. And there is an opacity scale. It actually was it's funny, I'm on the ADA Standards Committee. One of the things they were talking about is they want to require the dental companies to put the opacity score on the box. Right now, I believe, and I could be wrong on this, it's not required, but it may soon be or will be in the future, so that you and I can look at a box and say, hey, this is not very radio opaque. I don't want to use it.
Some of the older original dogs are like Carl Misch saying they're going back to zinc phosphate cement. Do you think if you're going to have excess cement, you'd rather have zinc phosphate?
I can tell you, it's a great point. Zinc phosphate on an implant crown probably works pretty well. You got to love zinc phosphate cement. So yeah, it's not a bad idea. The reason zinc phosphate might be a good choice as well, some dentists would use temporary cement. In the old days, I used temporary cement on my implants. Then I made the switch. I did screw retained, temporary cement, permanent cement. Now I'm back to screw retained. Zinc phosphate would be a good choice in some respects because it's probably not quite as retentive as some of these other cements, yet retentive enough to hold your crown in. See it on a radiograph. So if I got to retrieve that crown, I'm more likely to be able to get it out. So he makes a good point. Zinc phosphate, you got to love the fact, I don't know about you, but I've got 4 crowns in my mouth, gold crowns with zinc phosphate, and they've been in there for upwards of 30 years each. One of them's been in over 40 years. So you can say what you want about zinc phosphate cement, but if you got a crown that fits well, that stuff is pretty amazing stuff.
Yeah, I have 7 restorations in my mouth, inlays, onlays, crowns. They're all gold, and they're all with zinc phosphate cement.
But those crowns also fit very well. Remember the old days when you put a gold crown in, you couldn't get the sucker out. We used to leave the screw on them. Nowadays, we have such passive fits on some of these crowns. But, he has an interesting point. I've got to think more about it, but the zinc phosphate might be an interesting choice for your crown cementation in implant cases.
You know what? I should give a shout out to Dr. Sam Dominic. Thank you, Sam Dominic, for doing those crowns. I think Dr. Michael Glass did a couple too. Thanks for that, guys. Do you think a lot of dentists prefer cementing crowns on implants because it's a lot easier to do than to screw on an implant crown? Doesn't that take a higher skill set to have all your ducks in order?
I think yes and no. I mean, there are some cases, I almost think maybe, I used to believe that. Now that I'm going back to more screw-retained implants with the abutments, in many cases, it's actually easier. I mean, I screw that baby in, I take my radiograph, I tighten the screw up. Here's where dentists don't like it. Now I've got to cover that screw hole. Some people don't like it. I think it was more, maybe easier, but I don't think at the end of the day, if we did a study and I compared, you and I were doing 100 cases and we timed it and we looked at the amount of effort, I don't think it's a big difference. Where you get a difference is now I got to cover that screw and I got a patient who sees that screw and feels uncomfortable. My patients trust me, and I think when I explain to them why I'm doing screw retained, they buy it. So I don't believe it takes longer. I think we've been sold kind of a bill of goods where we think it's faster. We think it's easier, but I've done both, and I don't see a huge difference. In many cases, I'd rather screw retain it. I mean, there are times when an implant's done well, I feel like I should spend more time with the patient. I get them in. If it's done well, contacts are good, occlusion, I screw it in and take a radiograph. I talk to them for 10 minutes because I charge them too much money to get them out of there that fast.
Hey, when I first saw you lecture in '87, did you ever think back then you'd see the PFM go the way of the dinosaur? Can you believe we lived so long that we saw that the hottest new thing in the world now go extinct? What do you think about that?
It's amazing, and I agree 100%. I thought we'd see a slow decline, which we were, but when zirconia took off, and Glidewell had a lot to do with that. Glidewell, big lab, pushed zirconia. I'm not saying it's the wrong thing. They did something that was actually a pretty good idea, but they moved us in that direction. And whoops, sorry about that. I think I screwed you up here. Can you still see me?
Yeah.
Let me just do one thing. I screwed up. There we go. I think that we jumped on the zirconia bandwagon pretty quickly, and I'm not saying it's a bad thing. I do say to dentists, it was interesting that zirconia came out, and when you look at how fast that grew, and frankly, we are starting to get more data, but when we jumped on the bandwagon, we didn't have a lot of clinical data on zirconia. We had bench stuff. It hadn't been in the mouth that long. So I think it's been an amazing change. I'll give you an example though, where I'm doing a 3-unit metal framework try-in today. I've done a couple of zirconia bridges. I had 2 fracture on me, 2 zirconia frameworks in the mouth at the junction between the abutment and the crown. Had it happened once, had it happen after I did a full mouth reconstruction. One of the nicest guys in the world, one of my patients, 6 months into it, I get a call, your bridge fractured. So I've done the weird thing. I was doing a lot of zirconia. I still am for single units. I'm finding myself going back to PFMs for 300 bridges. I don't do a ton of 300 bridges because of implants today, but in some cases we have to. So it's interesting. I agree with you. I never thought I'd see the change. Another thing to be aware of, though, with the change in ceramics, the new, more translucent zirconia, the more aesthetic zirconia, and I had a talk with John Burgess, great guy. John's warning us that, when you make something more translucent, you sacrifice strength. So when dentists are prepping zirconia, a lot of them have this weird notion they can underprepare, and it's okay, it's zirconia. Well, at some level, there's some truth to that, because it's certainly stronger than, lithium disilicate is strong. Stronger than that, but you still have to be careful, particularly when we go to these more aesthetic zirconias, because to make them more aesthetic, we lose strength. So John Burgess and I were talking at a meeting, and he said he's got a concern with some of the testing he's doing that dentists have to be a little careful. You can't give me a 0.5 millimeter reduction on the occlusal, put in a nice, beautiful, translucent zirconia, and we don't know what's going to happen over time. I hope we don't see these fracture. So you still got to follow the basic principles. I always say to dental students, you know what, we're teaching you stuff. You may not think it's important, but 80% of the core that you learn in dental school, you're going to carry through your life. And adequate reduction, we teach them. It holds, whether you're doing crowns, veneers, zirconia, or PFMs. Still got to give me some reduction.
You know what I love the most about dental students and young dentists the first 4 or 5 years out of school is they try all the bleeding edge stuff. I
Yeah.
remember when I got out of school, the cosmetic doctors were saying do dicors and cement them with Duralon.
Oh yeah.
Then Horaeus Calzer came out with Art Glass. Iva Clara came out with Targus Vectors. Can you talk a little bit to, because podcasters are young? I'm an old dog. When I see something new come out now, I just smile and say, I hope all those 20-year-old something dumbasses try this and let me know in 5 years does it work. What kind of insight can you give the listeners today of how do you recognize advertising, marketing, and bleeding edge versus leading edge? Do,
That's a
do, do you just buy the kit and send it to the dentist across the street and say, "Happy birthday to you"? Tell me
it's a
next year how this worked for you.
That's a great question, and it's probably for young dentists one of the most important questions. And I tell them that in my lectures to dental students. I give them a ton of lectures here at the school. You got to be careful. I mean, choosing materials. I have a slide that I show them in one of my courses of the failures I've seen in dentistry, and you've named them. I mean, there was a point where I was at the Hinman Dental Congress in I have a plaque up there, 96, I guess it was, or 97. I'm lecturing at the Hinman group, and I said, be careful of composite to metal, because we're testing it, we're seeing failure. We had a 25% debonding rate. Next door was a dentist who ran an institute who had told the entire morning group that art glass to metal is the future of dentistry, composite to metal. I got a call on Monday morning from Horaeus saying, we had somebody in your lecture, we're very concerned about what you had to say. I got nervous. I was thinking, all right, who covers me if I get sued by a company? My malpractice isn't, university's not, it's not a university function. So I was a little nervous, and I remember saying to him, was there anything I said that you can prove is wrong? I have data from a study we're doing here. That became a catastrophic failure. Dicors, yeah, they look great until they all fracture. Remember Targus Vectors, you couldn't open a dental journal in the mid-90s where we didn't see a fiber-reinforced bridge. Look, Ivoclar is one of the best companies out there. Empress 2 came out. Empress 2 they were recommending for bridges. They were all fracturing. So for a young dentist, don't be the first on the block, don't be the last on the block. I mean, I think what you need to do is listen to people you trust, make sure they're not being bought by the companies, because we both know, you know as well as I do, there's a ton of people out there speaking who are getting huge paychecks by the companies to speak about technology and products.
What percent would you say?
God, I'm going to say at least half of them. I mean,
I wish you would right now document a list of all the names of the CEREC people who have been recommending the IMAX, the EMAX block, and now that Serona is bought by Dentsply, what percent of them will switch to the new Dentsply block?
Yeah, you're right. It's a tough call.
What percent will switch?
Oh God, I think half of them will switch because you know what? It's the bread is buttered on whatever side by whomever. One of the issues, though, you have, and I have this, so I do a lot of lectures. The dental societies are constantly coming back to me saying, "Who will support your lecture?" It happens every day that I get asked to lecture. So the problem we have as speakers, I hate doing that with the Sunshine Act and all the changes that have occurred and disclosure. I'll say to the company, I prefer you contact people. I give them a list of 8 or 9 companies, but you know what? They always come back to me. This happened this weekend. One of the societies came back and said, we'd rather you call them. So look, Howard, you're doing lectures, you're doing stuff on ceramics, and you've got a company throwing, $8,000 at you to do a lecture, covering your costs for a meeting. It's tough. I'm not defending the speakers, by the way, but I know why it happens. I'm not stupid. Now you're giving a presentation, you're getting supported by a company. You're not going to say bad things. You may not, if you're smart, you may not say things that are going to get you in trouble. So this has become an issue, I think. I think that what's happening with dental education is it's all corporate supported. And look, I fall into that. We all do at some level. I mean, I did a Dental Town one for you. I try to be as honest and as clean as I can be, but it was a corporate supported cement lecture. And the problem you have is when you're honest, sometimes you get bit. But the reality is when you're honest to the dentist, I've been out there a long time. I could have a lot of baggage if I had told stories. I never supported, frankly, I think of those technologies that failed because I always was concerned. I wouldn't lecture on fiber-reinforced bridges because I said, and I published in the Journal of Prosthetic Dentistry an article saying when we tested them, they fractured. We used them for temporaries and they were breaking. So the dentist has to be smart, the young dentist. They've got to learn to listen to people. They have to learn to question. They need to ask about disclosure. I mean, I can be supported by a company. I can still be honest, but I have to disclose I'm supported. which we're required to do now. You know, evidence-based dentistry is an interesting thing. We have an EBD website that the ADA supports, ebd.ada.org. It's a pretty decent website. And students can, and young dentists and old dentists, I don't care who, can go to that site with questions, and there's often systematic reviews. Now, I'm not telling you it's perfect. It's not perfect, but it's a good starting point. You might, like, I remember doing, when I started doing implants in the aesthetic zone, I said, you know what? I'm uncomfortable doing immediate place, immediate load implants. I went to that site, and to my happiness, I guess, or I found a bunch of reviews with some very good articles. Ironically, I'm reading one of the reviews that was written by H.P. Weber, who was in my practice. So I joked, I saw him on a Monday. I said, H.P., I don't know why I go to the site. I should just ask you, what should I do? But that's a good starting point. So be careful if you're a young dentist. Don't jump on every bandwagon. Find speakers you trust. Question the speakers that you're listening to. Make sure they disclose. And go to Dental Town, because you guys give good information. I think you really do.
But the dentists are at fault of this the most. Actually, the general dentists are at fault the most because, like when I started Dental Town in '94, it was subscription only, no advertising.
Right.
And only 4,000 dentists would give me $10 a month issue for the deal. So if you wanted to grow, you had to go advertising. So when only 4,000 out of 211,000 and say, well, I'll pay for information with no advertising link. And the same thing at a dental meeting. The average dentist makes $175,000. Why do we need a sponsor? I mean, if we're going to bring in a doc, you're a doctor. Let's pay this doctor like you, Ph.D., DDS, MS, come in and speak. Why do they need, what is this, a NASCAR race? What are they, rednecks?
Well, you know, the medical profession is a little different. If you go to a medical conference, some of them have sponsors, but you don't see a lot of speakers sponsored. My MD friends are always kind of amazed at the honorarium we pay dentists. In the dental profession, you know, people go out and they want $8,000 for a day, $10,000, some of these people for a day. In the medical profession, it's part of your obligation to the profession to give a presentation on material that you've collected, cases you've done. I think it's a little different. I know it's different. So we have a model that's very different for the dental profession. I agree with you 1,000%. I mean, look at the dental publications, and I understand why they do it. They can't stay in existence unless they get advertising. And so if a dental publication publishes a really negative article, and I'm not saying anything negative about zirconia, but let's say they publish an article about how bad zirconia is, they're going to lose all of the advertisers that support that product. So the dental publishers also have that issue. They got to sit and take a look at what they're doing and say, you know what, we got to make a living. So we really don't want to offend our advertisers. So we're going to be kind to them. I think that's what happens. It's a really tough time. I agree with you 1,000%. You should have Dental Town supported by all those dentists by paying you a fee to get honest information. You know, the clinicians report, love or hate Gordon in that group. I mean, they tried for years to do that. But they've become a little, you know, they've been around, they've been there forever. You don't see a lot of new things happening in terms of dental evaluations that are unbiased. That's the way I see it. So I agree with you 100%. I think dentists are funny. They're cheap about doing that. Dental meetings the same way. They don't want to spend money on those dental meetings. They want to pay nothing. And what do you expect when you're paying nothing? Somebody's got to support those meetings.
You get what you pay for. I'm going to take advantage of you since you have a MS in anatomy and cellular biology. One of the bleeding edge things I'm sitting on is when I saw that new Megagen bone tooth grinder, you know, right, where you extract the tooth, throw it in there. I thought of the last scene of the movie Fargo. You know, when they did you ever see that movie?
The woodcutter, yes.
What's that? Yeah, I mean, that's one of the greatest cult classic movies ever. If you've never seen Fargo, you got to see it. Just for the Canadian accents alone, it was worth every dollar of it. But you pull that extracted tooth and throw it in there, and I just thought, that's the coolest thing I've ever seen. But then I'm sitting there thinking, well, you're grinding up enamel, cementin, dentin, decay, bacteria, fungi, you know.
But they are actually they are sterilizing, in quotes, that. I've seen the system. I've not worked with it. About 2 years ago, a group up in upstate New York sent me information on that technology, and actually Dr. Weber looked at it. It's interesting. It's again comes back to the issue. I don't think they have a ton of data on it. It's really a matrix in a way for bone growth. You can't grow teeth that way, but you can actually get bone to grow. So there are a lot of systems out there that we use silk fibers. We have a patent on that. I do with a couple of people in biomedical engineering using silk fibers as a matrix to grow bone, or coating implants with silk fibers. But things are changing dramatically. I think that technology is probably going in the right direction. You and I are probably going to be sitting on a beach somewhere, drinking our pina coladas, getting wheeled around when this really takes place. People have been talking about, there's some people lecturing on growing teeth. We have a stem cell grant here to grow teeth. We're a long way off from that. But we're getting in that direction. So I think this you grind the tooth down, you sterilize it, you use it, and you 3D basically reproduce the existing tooth, put it back into a socket, is an interesting concept.
So you're saying autoclave, you extract the tooth, you're saying autoclave it, then pulverize it?
They somehow sterilize it, and I don't know how they do that, and then they put it back into the body. So there's the system I saw at least and it was coming out of, I thought it was out of Canada, the system I saw. So there's probably a bunch of them out there now.
Oh, okay. I saw the one out of Seoul, Korea with Megagen. When you talk about evidence-based dentistry, it's so confusing to young kids because a lot of the questions I get to Howard at dentaltown.com from some of my guests, I have some of the staunchest implantologists like Carl Misch and people from Noble Biocare saying that doing implants, like drawing blood and spinning it and platelet, just zero research on that, voodoo, whatever. But it's a hot growing fad. What do you advise kids when you see legends in implantology that have sunk 10,000 implants saying there's just zero research for that? It's complete voodoo when others swear by it.
Well, two things. You got a mouse, so on your computer, you can click. There's a ton of scholar. You can go to PubMed. You'd be shocked at how often I find information. So one, do the homework. I'll give you an example. I remember when zirconia got hot, and this is a couple of years ago. I've been doing zirconia. We actually did testing for 3M years ago on their zirconia, their lava frameworks. And I remember saying to an audience, how many of you are using zirconia? And there's 300 people in the audience, 80% of them put their hands up. I said, and how many of you have read one article on zirconia? How many of you have read one clinical paper, research paper? Nobody put their hand up. I said, so 80% of you are using a material that you've read nothing on, that you have no data clinically on. I said, don't you think that's a little scary? And then I go through my list of the failures. So my comment to these young dentists, if you got to remember, Carl Misch is a legend. Dr. Weber, who's at Tufts, they've placed thousands and thousands of implants. And for a young dentist who's starting out, really do some homework. Because I do talk to dentists who do platelets, they spin down platelets and they swear up and down. But you can't base it. You and I can do stuff in our practice and we can go out and lecture and say, we believe fiber reinforced bridges still work. Yeah, they may work in your hands because you know how to check occlusion, protrusive interferences, lateral protrusive. You got to think about the average dentist. So I think Carl Misch may be right. Maybe you don't need to do all that. I actually don't. But I do know dentists who swear up and down. And I always argue, too, look, if you're doing something and you're getting, a 98% success rate, then go ahead and do it, buddy. I'm not telling you to change a thing. But if you're doing implants and you're having trouble, then you need to take a step back and do some homework. But, it's not hard to find information. There's a ton of stuff. Every 10 seconds, somebody's publishing some paper on something in dentistry that's read by 10 people. I've published in scientific journals. Nobody reads it. I published in Dentistry Today. I publish in Compendium. I get read by everybody. And I'm not saying they're bad publications. So do your homework. Take your mouse. I always joke, it takes you 5 minutes. When we were in dental school or young dentists, I'd have to go to a library and spend half a day trying to find one article. I can do that in 5 minutes now on my computer. So do a little homework. Be smart. That's all I say.
I was published in JADA 4 times and still not one single dentist on earth ever came up to me and said, oh, I read your article in JADA.
Well, I had the same thing happen. I think the first time I published in Dentistry Today or Inside Dentistry, early on was the new publication. I had like 5 faculty members come up and say, I saw your paper. I published in Journal of Dental Research. Nobody's ever read it. I say none of our peers have. The people who've read it are researchers. The ones who should be reading some of that are dentists. They just don't read those journals.
I want to ask you another question. Back when I met you in '87, there were 15,000 labs. Now, did you ever think back then, 29 years later, there'd be half that many labs? So my question to you is, why did 15,000 labs, why did half of them disappear? And what are your thoughts on that?
First of all, I think we don't respect lab techs. So I think it's not considered a career that people want to go into. finding young people to become lab techs is virtually impossible. So that's one thing. I've lectured to their organizations or for different groups of lab techs a number of times, and they'll tell you they're not respected. Their income level just isn't there. The minute you start charging a lot as a lab tech, the labs want to go to the big, you got to glide well. It's like, why aren't any small pharmacies left? They've all been taken over by the big conglomerates. So these big labs have taken over the small labs. They do a lot of digital. I mean, now, they can mill your wax. So they don't need somebody to have do a wax up. They can then invest and press, lithium disilicate. They don't need to have somebody sitting doing wax ups. With digital models are becoming a little bit obsolete. BU went digital. They don't do models theoretically. So I think number one is the digital technology. Number two is small labs can't survive in this environment. It's just tough. It's kind of like small dental practices. They're not trained as business people. I used to work with some small labs. I still work with one small lab. I guess you'd call it small. But I had one lab or two labs over the years that were 2 or 3 people. They went out of business because they didn't handle the business well. They couldn't compete with the big labs. They just didn't have the resources. Plus, you talk to these guys and gals that are doing this stuff, they're making 50, 60 grand a year and getting yelled at by us because we do lousy crown preps. We under-reduce. Then we give them crap because we say it's their fault. You know what? Why do it? So it's, I think, a whole cadre of reasons why labs have dropped. I didn't expect that. But I guess had I really thought about it when we were talking together back in the mid-late 80s, we probably could have predicted this. I mean, CAD-CAM was on its way. You talk to lab techs and the small businesses, they were complaining all the time. I mean, in a weird way, look what's going on in dentistry. What's happening to the small mom and pop? You own a dental practice with 3 people in it. They're going, boy. It's all corporate now. I mean, you see the corporate dental groups, big group practices, people opening 8 or 9 practices is considered not even that big anymore. It's our kids are coming out of dental school taking jobs. And they're not thinking of buying practices out of dental school. They're looking for jobs out of dental school. So the whole world is changing, buddy.
One of the things that fueled the small lab was, 96 out of 100 crowns sent to Glidewell are a single unit, a molar on a triple tray. Right. And now you probably have 15,000 American dentists who switch that out with a CAD-CAM. What do you think of CAD-CAM?
I have CIRAC and E4D in my practice. My feeling on CAD-CAM, and I feel this very strongly, it's only as good as the person behind the machine. I have seen some incredibly well done CAD-CAM crowns. I have images of some CAD-CAM crowns I've done that I think could go up against any lab process. I've done a paper, we published an abstract in the Journal of Dental Research. We did pressed with 2 labs. We did CAD-CAM. We blinded the evaluators. They rated them pretty much equally. As a matter of fact, the CAD-CAM did better than one of the labs. But the problem, I think, is the dentists that are doing CAD-CAM. It's a great technology, but you're in a practice. You got a busy practice. You think like a businessman. You have a business degree. I have some business training. When you do CAD-CAM, you've got to change your model of how you practice at some level. So I throw a person in a chair. I do my prep. I do a scan. Sometimes I'm inefficient. I spend too much time. I should be next door. I should have somebody who knows what they're doing, milling that crown. I try it in. They should stain and glaze. Now the crown comes back, and now the margin doesn't fit. That patient's expecting a crown in a day. The margin's off. What do I have to do? I got to rescan it. I got to remill it. I mean, that's what I got to do. Now the patient's going to sit another 30, 40 minutes while I'm doing all that. I think a lot of crowns get cemented in that shouldn't be cemented in because the dentist knows better, but doesn't want to spend the time, hasn't thought about how to design his or her business model to make it work. So, I think that the problem is with the dentist. The technology is getting better and better. I mean, I was trained on the CIRAC 1, the CIRAC 2. I mean, when you look at the OmniCam now and how easy it scans and the images I get, it's here to stay. It's exploding. I mean, we teach our kids CAD-CAM at the dental school, and that has absolutely affected labs. I mean, you think about it. I mean, unless you're a lab tech, who some of them are doing this, they're selling themselves out to offices, going in a couple of days a week to dental practices and helping them with their CAD-CAM in the office. But, it has affected labs. It's affected how we teach dentistry. I agree with you 100%, but I do think CAD-CAM is a good technology. I think the dentists have to be meticulous. But how many crappy PFM crowns did I see? I did a paper in JADA in 2000 we sent to 400 labs. We monitored the crowns and the impressions they were getting. The numbers, if I'm not mistaken, were 36% of the impressions were not readable by the labs. This is in 2000, before we were doing CAD/CAM. If 30-some-odd% of those crowns, and it was in a paper I published, you can't read the margins, then you know the crowns can't fit that well. So I always say in my lectures, probably 20% of the crowns being cemented in Boston today have open margins. You know, so don't blame CAD/CAM. When people say CAD/CAM doesn't work, and I've heard prosthodontists say this, no, that's not true. The dentist didn't work. CAD/CAM works. They got to be trained. They got to be meticulous. I mean, dentistry is a tough profession. You know, there's the easy way and the right way. And often the easy way is often not the right way. It takes time to do it right.
You're talking to tons of millennials right now under 30. Almost no one has ever been seen at our age listening to a podcast before. When you get all the feedback and everything I can track on a podcast, probably 20% of them are in dental school and the other 80% are under 30. So they're all doing this behavior because they're commuting to work. They also always tell me they hate radio. They can't take any more listening to the election, or they don't want to drive to work listening to commercials, and so radio is just dying. They can't listen to another Trump Hillary scandal, whatever. So I think that's been the tailwind of this show. Nothing explains how great this show is doing except for getting guests like you on. But she's driving to work right now. She's working for a corporate chain like Aspen or Heartland, and she's going to start her own practice, and it's all that. Her big question is, that machine's $150,000. I want to be a great dentist like you someday, Gerry. I've already got $350,000 of student loans. Really? I'm putting this up. Should I? Yes or no?
All right, it's not a yes or no answer, as you know. I think one advantage of going to Heartland and these corporate dental groups is a lot of the younger dentists have an opportunity to try technology because they're not buying it. The corporate dental group is buying it, so that's one plus. You can do great dentistry without CAD/CAM. You and I both know that. I mean, I can take impression materials work well. We've got great silicone materials out there. I can take an impression, I can find a good lab, I can do quality dentistry. So do they have to go out and buy a CAD/CAM system? Absolutely not. They don't have to. If you're a young millennial, the difference between the two of us is when I went for training on CAD/CAM, it was tough. I went with my dental assistant, who's now a dentist. She went to dental school, but at the time she was my assistant. She's now working out in Colorado. We were trained together. She was like 10 minutes into it teaching me the crap I was doing wrong because I'm not a millennial and I don't know how to play computer games and I don't do that. So these kids are totally equipped to do CAD/CAM. They'll pick it up fast. They just get it, the majority. So that young millennial going to work, I think you graduate, you got to be smart. You got to pay your debt back. You got to own a home. You may have a family. You look at what you're generating. If you're going to bring CAD/CAM in and you're going to lease it, you need to look at what your needs are. When you get busy enough that you think bringing a system in that can do chair-side crowns is worth it, and you can train your staff, and you can make it so that you can crown prep, go into another operatory because you're busy enough, do another procedure while you got a trained staff person doing the milling, doing the staining and glazing, who you're paying hopefully a decent salary, but they're not making what you're making. I think it's a good technology. I think that it is something they should certainly think about. The number for the price is important, but you got to look at what it generates for you. Then you subtract your lab bills. But I think dentists don't do that. Number one, they say no because it's too expensive. They don't think about it. They don't have a business plan. Or you get the other ones who do the opposite. Oh, it's CAD/CAM. I'm going to buy it. And then it sits there, and they don't really understand how to make it work. And they be and moan that it's not making them money. So the reason I say it's not a yes or no answer. Yes, CAD/CAM is a good technology. Yes, it can make dentistry good for you and fun. I mean, don't forget, we want to have fun. Some dentists love. I got a partner in my practice. He loves CAD/CAM. He's in his 50s, late 50s. He loves technology. He'll do CAD/CAM, not even so much that he wants to get a good crown, he just loves doing it. So you got to weigh it. Do you have to have CAD/CAM? No. Do you come out of dental school with, these poor kids come out, they owe $500,000, $400,000. They haven't bought a house yet. They haven't bought a practice yet. They haven't paid for their car yet. They haven't taken a vacation yet. I mean, think about it. I graduated, I think, 50 grand. I was devastated. Today, if somebody owes 50 grand, they're celebrating. They're opening champagne at graduation. So be smart, maybe don't do it immediately out, plan for it. Plan I'm going to go CAD-CAM 3 years into my private practice. You're buying a new office, you're buying shares, you're upgrading. So have a plan, have a 5-year business plan for your practice. Maybe the 3rd year of that is you go to CAD-CAM. Take a few of the courses, learn. So it's exciting to be a young dentist today, but it's also kind of scary. I mean, when you owe that kind of money, it's not an easy time to be a career dentist.
For the average dentist out there, I mean, there's 211,000 Americans who have a license to practice dentistry. So many of them you just hear say, well, aren't you supposed to do all zirconium on the back and cement them, and then all Empress or Emax on the front and bond them? Is that just overly simplistic?
Yeah, I think it is at a certain level. I mean, I know that, yeah, if you had to, put a gun to my head and say, what would you do? That would be a good choice. Some dentists will tell me, there's a couple of very good prosthodontists in town who do Emax everywhere. They do anterior, posterior. They understand occlusion. They know how to prepare a tooth. If you want to go all ceramic, assuming you call zirconia ceramic, I guess it is, you do ceramic in the back, zirconia. You can do Emax in the front. You're right. You bond the Emax, you cement the zirconia. One of the reasons people like zirconia, by the way, it's cementable, so they don't want to bond. Dentists don't like bonding things in. They don't like doing bonded restorations. They don't like bonding their crowns in. I know some very good dentists who still do PFMs. I mean, look, I've seen some beautiful PFMs. If you can reduce a tooth, and you've got a lab who knows how to do porcelain fused to metal, it's not a bad restoration. I always joke. I have 4 gold onlays, actually. I called them crowns earlier, but they're onlays. I have 4 gold onlays. They're on my first molars. Not aesthetic, I guess, but I'll be buried with those 4 gold onlays in my mouth. And they're amazing. Gold is an amazing restoration. Try to get a patient to do a gold restoration in the back of the mouth on a second molar today. I mean, on a second molar, in a case where you can't see the second molar, and they will still argue. So you almost don't have a choice today. Gold has really died more for the aesthetics than certainly the function. You can argue, and I try to get people sometimes to go with gold. They won't do it. The problem with zirconia in the back of the mouth is if you know how to polish zirconia. Think about zirconia against zirconia 30 years in somebody's mouth, like my gold onlays. Gold against gold is very forgiving. I don't wear that gold down. Gold against gold holds up forever. Zirconia against zirconia, when you went in the mouth when I delivered your zirconia crown and your bite was high, and I ground on it with my diamond, and then I spent 5 minutes, not 5 minutes, I spent 1 minute polishing it with a rubber point. Now I let you go home. Now you've got a zirconia not polished correctly going up against another zirconia, or maybe worse, a natural tooth. So if it's done right, I keep saying this, for the young dentists out there, when I give a lecture to dental students, I said, look, pay attention now because I'm going to save you a lot of money down the road. I said, if you don't listen to me now, you're going to have that failed restoration. You're going to say, I should have listened to Dr. Kugel. Or you're going to pay a lot of money to come back and hear me say the exact same thing to you again later. They always laugh. And I tell them for a reason, because the basic stuff that you learned. I mean, when you polish a restoration, like zirconia, polish it correctly. When you go zirconia against zirconia, we don't have a lot of data on the wear of zirconia against zirconia long term. So yes, that's not a bad choice. Does that mean it's the only choice? No. Does it mean that some of the new materials coming out, the hybrid materials which are being developed, may be better choices? I don't know the answer to that. But right now, if you ask the average dentist, they would give you that answer. Zirconia in the back, lithium disilicate in the front, bond cement. If I talk to a dentist, if I could find a dentist doing second molars in gold and their patients would accept that, I'd hug the guy or gal and say, God bless you, because they'll keep those forever. But you just don't see it. So the long answer there is yes, that would probably be a decent choice.
The kids always get mad when a guest doesn't speak name brand. So what exactly would you cement the Emax with in the front, and what would, bond the Emax with, and what would you cement
if I use a couple of products in the front of the mouth, if I'm bonding in Emax, I like Multilink. Ivoclar makes a good cement. They've made it for years. It's a dual cured cement. It's got a bonding agent. I believe they ended up putting adhesive in it. It used to be a different agent. You have 3M makes Reliax Ultimate, which is their cement, which is very similar to Multilink. So I would think those are good products. For the posterior region, you could put in your zirconia with Multilink. The problem with zirconia is you got to cut that baby out. So when you put a cement in that's more retentive for the zirconia crown, argument is I don't want to cut crowns out, so why am I thinking about getting them out? I've had the misfortune. I get a lot of referrals in my practice of cutting out a lot of zirconia crowns. It's a friggin' nightmare. I cut 6 out in one patient because she was unhappy with the work that was done by her dentist. I remember it took me hours to cut those babies off. So cementing, you can cement with the same cement anterior posterior. You could do the multi-link for the front and back. You could in the back of the mouth go with something like a Reliex or a Speed Sam, a self-adhesive. I don't think you get the retention quite that you would get, but on a zirconia crown, it's a cementable crown. A lot of dentists go with resin ionomers on their zirconia, and they seem to be very happy. So you have a lot more choices on zirconia. On any pressed, whether it's the Dentsply material, whether it's Ivoclar's material, you got to bond it in. And in this case, Multi-Link, Ultimate would be good choices for those products. You know, veneers, you got to bond in, so use a resin cement. You know, Reliex veneer or Ivoclar's veneer cement would work well too. I tend to go to those two companies. They're both very good, reliable companies. And there are other good products out there. So I will tell your group, if one of your young dentists is cementing stuff in, and you know, I always say when I lecture to groups, young or old, if you're happy and you're successful, you know, and you're cementing in with zinc phosphate and you're happy and things aren't popping out, God bless you, don't make a switch. But if you're looking for something or you're not comfortable or your patients are having sensitivity when you cement stuff in, now you need to take a look and say, all right, I need to do something better. But you can't argue with success.
So speaking of doing something better, faster, easier, lower cost, there's a lot of seduction marketing about bulk fill. I mean, my God, it's just so much. It would just seem like awesome to be able to just fill the whole damn thing up at one time and cure it. Bulk fill, bleeding edge, leading edge. Is that more marketing and hype, or is it there, buddy?
It's there, but here's the problem with the bulk fills. We tested bulk fills. I've done abstracts on them. I presented at the IADR research meeting on them. We've always found, and they've been around for a while, they work pretty well. Where you pay a price is the aesthetics, a lot of the bulk fills. The bulk fills are very translucent because you got to get light to penetrate. They also don't cure. Some of them will cure with certain lights. Make sure you check that your light is compatible with your bulk fill. So I do think bulk fills are okay. Some people will say do a bulk and veneer over it. You know, I tend not to use a lot of bulk fills in my practice, partly because I don't feel the need for them. Doing a 2 or 3 layer composite doesn't bother me. For those dentists who want to get it in, do it quickly, most people, I always say to dentists and dental students, people are different animals in the front of the mouth than the back of the mouth. You can do a posterior filling on tooth number 19 and they look in a mirror and they're comfortable with it. So you limit the bulk fills to the back of the mouth. You pay a price aesthetically on them. Do they polymerize? Yes. Do they seem to hold up? Yes. So it depends on your needs as a dentist. Some of the other ones that are interesting, and I call it a bulk fill, you know, Activa Restorative is a dual cured bulk fill restorative. A lot of pediatric dentists like it because it's also, in quotes, bioactive. So they use a bulk fill bioactive on kids, and that's kind of nice because I take my gun. I don't want to be layering composites on a kid. I squirt my bulk fill restorative in, light cured. It's dual cured anyway, so if it's not fully polymerized with my light, it's going to set. I take a burr to it, I finish it, and I get the kid out of there. So certain of the bulk fills, like that material, would be really kind of nice for a pediatric practice. I don't know if you've seen it or used it. It's a nice man. We've tested it, and I've tested it without corporate support, particularly recently. And to my surprise, it seems to keep doing pretty well in all our testings. Strength, compressor strength, wear, fluoride release. So some of the materials out there are kind of interesting. So I would say thumbs up on bulk fills, but depending on the kind of practice you're running and what you feel comfortable doing in your practice. I don't use them a lot, but I have colleagues that love them. There's 8 of us in my practice. I got one dentist who loves bulk fills, and I just don't use them all that much.
When one of your students says they want to be a pediatric dentist, do you first get a psychiatric evaluation on them to see?
You know, I was just laughing. Yeah, you got to. I'm with you, man. I got to say, I do only adults, and it's a lot of prosto. But you know, I worked in a practice for 2 or 3 years in Rhode Island. We had kids. I love kids, but I don't love them when they're in a demo chair. So I have enormous respect for pediatric dentists.
Oh my God!
I do mission work. We go on these trips. We always bring a couple of pediatric dentists, and we do this at an orphanage, one of the places. And these are kids that have a lot of issues. I mean, they're brain damaged kids, and I had to walk out of the room one time watching these pediatric dentists work on this young kid because I couldn't take it. And we were having drinks that night because you have to have a lot of drinks after that. And I said, you know what, guys, you guys are saints. I don't know how you do it. And I said, and you know what, it's funny, I have enormous respect for pediatric dentists. He said, you know, Gerry, it gets to a point where I get so used to it, I don't hear it anymore.
Oh my God.
That kid comfortably. You and I would go crazy. I mean, I couldn't deal with it. So no, do pediatrics. If you do it, you're a saint. Just don't ever ask me to come into your practice as an associate or a partner, because I don't want to do it.
You know, I told my oldest sister, who's a Catholic nun, I said, you know, I don't know if you're right or wrong about the afterworld and heaven and hell and all that, but I'll never do anything immoral because I'm afraid if I do go to hell, that I'll be a pediatric dentist for eternity. So God bless the pediatric dentist. So you mentioned another hot buzzword that's very confusing to young dentists. They keep seeing marketing deals that switch to this product because it's bioactive. So will you just review, what does that even mean? And is it bleeding edge? Is it marketing? Is it real?
I think it's real. I think it may be bleeding edge in some respects, but there was a lecture I heard, is it bioactive or biobull? I think it's real. Bioactive is real, but the definition, my definition, Steve Jeffries, who's down at Temple, did a nice review of this, a great review. Bioactive has to produce, theoretically, hydroxyapatite or HA-like, a surface that's HA-like. Most, like a glass ionomer, before I did any homework, I would have thought a GI, glass ionomer, would be in essence a bioactive material. It chemically bonds to the dentin, it releases fluoride, but what it doesn't do, it doesn't form hydroxyapatite. So like Activa is one product where they put calcium phosphate and fluoride in the product. We did a study, we did a scanning study. Now we said it looked like it was hydroxyapatite-like. One of the reasons some of the companies have been a little cautious about claiming bioactivity is they don't have evidence that they form HA. Theracal, which is another very interesting product, which would be in essence bioactive. From what I've read of Theracal and I've seen, it is a bioactive material because it forms hydroxyapatite. You know, MTA would be bioactive. Bioactive bone materials have been around for a while. So I think it's real. I think maybe, though, what we don't really know, because we don't have clinical data, is clinically long-term, do they really make a difference? If I you have a big cavity and I'm on top of your pulp, if I were to use calcium hydroxide, RMGI, and a restorative, would I get a better result than using Theracal and a bioactive filling over it? Theoretically, I should do better with the bioactive material because I'm getting hydroxyapatite formation, I'm getting remineralization. So I think the material I mentioned, the Activa restorative, for pediatric patients, what do you got to lose? It works well. You just theoretically have to etch. They're telling you you don't need to do a bonding agent. And it's bioactive and it's got calcium phosphate and fluoride. Time will tell clinically whether these materials work. But you have to ask the company that's selling you the bioactive. And there are a bunch of them coming out, by the way, because I was at the ADA meeting and a number of companies are coming out with bioactive products. First thing you got to say is show me evidence that you form hydroxyapatite. Show me evidence you form anything like hydroxyapatite at the interface. And do you have any data on your product other than some bench studies? I think most of them do not. So bioactive's here to stay. The bioactive cements are getting hot now too, because I think there are 3 of them. You know, Doxa cement is a bioactive cement. The interesting about Doxa, which is from Ceramura, Doxa makes it, it's Ceramura cement. The Doxa company makes a cement that I've always had trouble when I test it, when I look at it in the lab. But yet dentists who use it tell me it works well. If it's bioactive, it may work well because over time, if it forms hydroxyapatite, it gets better as it gets older. So we'll have to see. I think they are kind of cutting edge. But with, I say cutting edge, but I have the caveat we need to give them a little more time.
I can't think of anyone sharper in dentistry when it comes to dentistry research. You're amazing. And another big bag of confusion is everyone talking about the oral systemic health connection.
Sure.
They'll come out with a little study. This disease had, you know, some bacteria in it, and that's also in the mouth. How are we? What should we know about the oral systemic health connection? Is it correlation? Is it cause effect? I mean, they're linking this to pancreatic cancer, to Alzheimer's, to. I mean, there must be 5, 6 different things that you see it people posting on social media about.
You know, we did an article in Inside Dentistry when I was the editor on the oral systemic link 10 years ago. I mean, you and I both know this is not a new topic. When we were dental students, people talked about it. What always surprises me, we've done a lot of talk, we haven't done a lot of action. And by that, I mean we don't educate students well on how to look at the oral systemic link. Is it real? Yeah. Is it hyped? Yeah, probably so. I mean, Jenko and their group at Buffalo did a lot on low birth weights. I think a lot of that has absolutely been shown to be true. Low-grade infections like gingivitis produce factors that get into the bloodstream that could have an effect certainly on offspring and on heart. We talk about heart muscle being affected. So I think there are certain things that are well documented. I do agree with you that I think we're getting a little carried away sometimes with some of this. Where I think we've made a mistake, we have an oral medicine course at our school at Tufts, which is Dr. Gonda runs that course. Great course. She does a great job teaching dental students. I think we don't do a great job integrating medicine, dentistry. I spent a couple of days at a dental school down in, it happens to be, I was in Erie. It was Lecom Dental School. They do a nice job where they bring their pharmacy students, they bring their dental students and their medical students together to do rotations. And they go to extended living facilities, and the students go around those facilities and diagnose, treatment plan patients because they believe in the oral systemic link. I see a trend in dentistry where we're becoming pushed toward doing more medical treatment. I mean, we should be diagnosing diabetes in our dental offices. These salivary analysis, these tests that are coming out now, there's so many things that are happening in that area where you can take somebody's saliva and I can determine, whether they've got a heart problem. I can determine if they have diabetes, sickle cell. I mean, we can do all of that in our dental practice. Why haven't we done it? And you know the answer. We don't get reimbursed for it because we don't get medical insurance. Sleep medicine, the best example. It's going crazy. I mean, we do sleep medicine in my office. I took another sleep medicine course a couple of weeks ago. If you become boarded by the Academy of Sleep Medicine, you can, working with a physician now, get medical insurance to cover your sleep appliances. There's a perfect example. Try to sleep with a CPAP on and have any kind of romance in your life or feel comfortable at night, but some of these sleep appliances work very well. So we're bridging that gap. A young dentist today should be very aware of the fact that salivary analysis, doing blood pressures, diagnosing certain diseases that are well documented may be something we have to do more of. We should be doing it anyway. Even the model of medical dental joint practices, there are a couple of them popping up. And I've been approached by a medical group in Boston to see if I'd be interested in opening a medical dental practice with them because it's happening more and more. So the oral systemic link is real. I don't think we've done a good job in dentistry understanding it. I think most of your young dentists out there haven't really thought about doing medical diagnosis. I mean, I hate to say it, you're a doctor. And the oral cavity, if you can diagnose by doing salivary analysis and looking at soft tissue, I've referred people to physicians, they've been shocked. High blood pressure, diabetes, because I could see the gingival tissue. And I said, you know what, you ought to see your physician. The doctor acts shocked that as a dentist, I referred them for an exam. But we should all be doing this. So it's real. Is it hyped? Absolutely. We hype a lot of crap in dentistry. But we should be doing it. And I think we're just not doing it a lot. We need to educate students better. Dental schools aren't doing a good job. So once that happens, and it's happening, it's going to be better for dentistry. And I would like us to get reimbursed for this, and hopefully that will happen.
I've done that oral DNA labs test on myself.
Yeah.
And 3 times in a row, it came back and said, "You're dead."
Well, they were right.
Hey, I'm going to go back to, I like whatever, I guess, someone our age, because the average dental student, I mean, admit it, that they're old enough to be our children.
They are, yeah. Sometimes.
I mean, my oldest is 27, so, they're our kids. And I just like to share lessons from, our generation to their generation. It seems like dentists always like to try to overcomplicate everything. They don't like to do anything easy and simple. And when they overcomplicate it, it leads to higher overhead. Like you were talking about a zirconium bridge, and and now you're going back to PFM. I find myself going back to Impergum in a sightless Premier triple tray and send it to the lab man who only lives a mile from my office and comes by and delivers it and shakes my hand and brings me a donut. I mean, I'm going back to that. But something that I see, and I want you to weigh in on this. Do you think, the religious mindset that you're missing a first molar and we're dentists, so we go to the church of teeth, so we don't want to file down the sacred cow teeth? And I look at some of these implant disasters where they were missing a tooth and they didn't want to file down enamel because it's religion. but they have no qualms of blowing out the sinus, packing it with paper clips and cow bone and chemicals and all this crap. Do you
Right.
sometimes think that, do you think a 3-unit bridge from a second bicuspid to a second molar is an immoral act and Jesus is going to spank you when you die, but
No.
blowing out a sinus with a hand grenade is perfectly okay?
No. So here's a good example. I have a bridge. I don't think I'm trying a framework in today. It's a 80-year-old woman. She had fractured a tooth. We lose it. She's got a space there. She has large filling, a crown on the other tooth. I could have put her through an implant, and I gave her the option because you don't do an implant because of age. But I said I can do a bridge, can do it quickly. It'll be 2 visits. I'll prep, take the impression. I didn't scan it, sent out my impression. And Improgum is still a good material. I use silent polyvinyl siloxane, but send it out and get the framework back. Yeah, I could have pushed an implant on her. I'll give you the best example. I had a patient, went down to New Jersey. She's missing teeth. She had a partial denture that I had made her 20 years earlier. She broke the partial denture. She goes into a dental office. She's visiting her daughter. Dental office says, oh, implant. She calls me up from her daughter's and says, I just went, I had an emergency, and he wants me to do 12 implants. She's 78, and I broke my partial. Maybe I should do this. I said, were you happy with your partial? He goes, yeah, I never had a problem with it. Were you comfortable? Could you eat with it? I go, yeah. So I called him up, and I wasn't calling him out, but I said, so you treatment planned her for 12 implants. Why didn't you just fix her partial? She told me on the phone she's happy with her partial. She has some disposable income, but you're going to suck away a big chunk of her income when she's at her age and she's comfortable. He said, well, you have a point. We'll make her a partial. I mean, there's a good example. Why do an implant on somebody who's comfortable with a partial denture? I do agree with you. When your only tool's a hammer, everything looks like a nail. I mean, when you do implants and you think that's the way to go, every hole in space. I've had patients come in missing a first molar for 20 years. Older patient, they're in their 60s now, and they say, doc, the periodontist said he wants to do an implant there. And I'll say, well, how long have you been missing that tooth? I can't even remember when they took it out. You having trouble? No. You eating fine? I said, you realize you can live without that tooth. I mean, if you're comfortable right now, you don't have to have a tooth put in there. And they'll say, but they act surprised, like, really? I'm like, no, you don't have to have a tooth in there. So I've gone the other extreme. Forget the bridges. I've told people, look, if you're comfortable, you can live without that space being, second molars are a good example. I've had patients lose second molars, and the surgeon then says, oh, we'll get you back into an implant. After the tissue heals, I'll say to the patient, now you've been missing that second molar now for, a couple of months. How do you feel? I'm fine. You chewing all right? Yeah. I said, and say they don't have the wherewithal. I'll say, you know what? You can do the implant if you'd like to do it, or you can live without that second molar. Well, why didn't the surgeon tell me that? I said, because they're a surgeon. They place implants. That's what they do. So
that's a great point. In my 29 years, I just celebrated my 29th anniversary at my dental office, and I never had anyone miss a wisdom tooth in 29 years. And in 29 years, only 3 people who I extracted a second molar and didn't even recommend to do anything, just, it's gone. Only 3 people came back and said, you know what, I miss chewing on that side. 3 people, it's 1 per decade, miss a second molar in my office.
But you're a realist. I mean, I think, yeah, you're right. I mean, so these kids come out of school and you're trained a certain way, and they've got a oral surgeon who's great and a periodontist telling them you place implants. The reality is when you want to grow a practice, try to get an appointment in my office. You can't, because people trust me. And I have a saying I say to my patients. I'll say to them, I never do dentistry for me. Dentistry for me would be to put an implant back there. I want to do dentistry for you. Do you want that? Do you need it? If they say no, well, then I do dentistry for the patient. Dentistry for me would be to pop an implant on everybody, everywhere. But that's not always the best thing. And if you do dentistry for your patients, you're going to be busier than you can imagine because they're going to trust you. And I truly believe that, because I see dentists in my area. I'm in a very good area. I'm in Back Bay, Boston, who do work that I look at and I think, oh my God. Or I'm out of town and I have an emergency. They stop in some office like this woman and they're telling her she needs 12 implants. When, by the way, this is about 9 years ago. Her partial was redone. She's still got the partial and she's happy and she's in her late 80s and everybody's good and she paid $1,500 for a partial denture. I mean, so you're right. Sometimes we overdo it. I mean, you got to look at we don't look at the teeth, look at the patient. I mean, look at their needs, look at their wants, look at their age, look at their health, and make a decision. Look at the bone. I mean, sometimes on a 75-year-old patient, doing a bone graft isn't the best decision. So, and I'm lucky. very lucky that I've got two surgeons in my practice, Dr. Weber and Dr. Schmarty, great surgeons, and they know what they're doing, and they only do dentistry for the patient. And I say that they don't do dentistry for them. They don't need to do dentistry for them because they make plenty of money. You know, they don't have to push implants on people or procedures not necessary.
Hey, you're the busiest guy in dentistry, and it was so hard to get this time with you, and I went over an hour and 4 minutes, but I had just one last question. Can I ask one overtime question,
Yeah.
even though I'm already 4 minutes overtime? You know, when I, you know, it seems like the human condition is they just believe what they want to believe, and they don't really, you know, and they don't like facts. And with regard to when you and I got out of school, it was indemnity insurance, where we submitted them the fee and they paid a percent. Now, 82% of dentists are sent the fees with a PPO, and that average fee is 40% lower. In fact, when you and I got out of school, the number one overhead in a dental office was labor at 25%.
Right.
Now, 30 years later, labor is 28%, and it's not even the number one overhead. The number one overhead is the adjustment fee off the fee. You charge $1,000 for a root canal, they pay you $600. The $400 adjustment off the fee, the PPO adjustment fees, is now more overhead than labor, yet adjustments don't even show up on your P&L. So my question very succinctly is this. I understand composites and tooth-colored restorations and all that for all the girls on earth. I get it. But amalgam for boys, I mean, when I see a PPO fee and it's a 7-year-old boy that hasn't brushed his teeth, he's got a burger hanging out of his nose, he's worn the same Boston Celtics shirt for 4 days in a row and wouldn't even know what deodorant is. If you place on a 6-year molar, the kid needs an occlusal, or let's go with an MOD on a 6-year-old boy. If you did that in amalgam, how long would that last? If you did that with an MOD composite, how long would you last? Because every dentist on Dental Town says that, well, the way I place my composites, they last longer than amalgam.
Well,
What would you say to that with a PhD?
I would say that's probably not true because we always think, well, we do works. That's why you can't do evaluations and research on your own placement of restorations. The data shows, of course, the data was about 2011-12, the NIDCR, and you go to their website, with their practice-based network, looked at the average lifespan of a composite. Their data showed the average life on a composite was 5.6 years. Now, so, you know, you can say what you want and in your practice, but, you know, and maybe you're doing it right. But if you look at the average dentist, they don't keep the area dry. They don't isolate, whatever, dam, isolate, whatever you use. You know, I do bonding courses. Half of them don't know how to use their own bonding agent. They're using it wrong. So the Dental Town group is maybe different because they do listen to this. So we're preaching to the converted here. But the average dentist, they're just not doing them right. The beauty of an amalgam, love or hate them, even if you screw up an amalgam, even if you get it wet, it's going to have a lifespan that's longer. If you look at the data, there was a study done in the Journal of the American Medical Association, 500 kids. Forsyth was involved in the study. Half got amalgam, half got composite. They looked at mercury, they looked at cognitive skill sets. You know what they found? Nothing happened to the amalgam kids. The only difference was the amalgams lasted significantly longer than the composite restorations that they placed, and they used comprimers as well. So one of your young dentists claiming that composites last longer, do a little homework. You tell them to go and do a little bit of homework on that. Now, that doesn't mean they place amalgams. But if they're standing in front of me and they're bad-mouthing amalgams, I've got amalgams in my mouth that were put in when I was 8 or 9 years old. Yeah. I have a first molar amalgam that's still in my mouth, and I'm 25 now. I mean, think about that.
But what would you say when Dental Town isn't even? I mean, it's as a 250,000 dentists now, 250,000. So, you know, it can't lean towards older, younger. Girl, boy, it's the whole sample size. How long would you say the average amalgam lasts versus the average composite in the United States of America today?
Yes, I'm going to tell you, I think probably twice as long based on the 5.6 years. I think your average amalgam, and I've read some literature on this, and it varies, but you're looking probably 10 or 11 years on an amalgam. You're looking at 5.6, 6 years on a composite. Now, I've been doing posterior composites since 1985, so I can go head to head with anybody doing composites. And I even say to my patients, I can do a composite as well as anybody in America, posterior composite. But if somebody wants an amalgam, I've had people ask for amalgams. I've got patients. My practice was opened in 1923, the original practice.
Are you serious?
Yeah. So we're still running the practice since 1920. Murray Gable started it. He was a legend in dentistry. He's got patients that he did amalgams on that they're in their 90s now. They need a filling done. What am I going to tell them? That was a lousy restoration that you had in your mouth 60 years. I'm going to take it out and put in a composite. So I will place, rarely, but I place amalgams. And you know what? It's not a bad restoration. People who tell you it is, fine. They argue with me as well. It doesn't mean that they should go out placing them. But I'll give you we do a lot of mission trips. We were a couple of years ago, maybe it was 5 years ago, in the Dominican. The students all wanted to do composites. They were all hyped about doing composites. But we had amalgam. We have 200 people online. We had 2 dental chairs, 1 working handpiece. So the kids are doing a composite. First patient, posterior composite. Oh my God, they're like 40 minutes. So I called the group together. I said, guys, this is not about you. It's about them. Get the amalgam out. I said, I will prep all these teeth. You fill them. And we were extracting teeth as well. We pounded out, and I love this. We had 1 handpiece, 2 chairs. So I'd stand. I'd have 1 in each chair. I'd drill this one. I'd say, fill it. Drill this one, fill it. And we were going back and forth. We had autoclaves and we're autoclaving stuff. I get pumped up. I get like, I would have liked battlefield dentistry. That's fun to me. But that amalgam saved the day. So in third world countries and poor communities where they can't store up composites, which are heat sensitive, by the way, where they can't afford it, composites are expensive. Plus you got a bonding agent. Plus you got a curing light. Amalgams, the World Health Organization wanted to ban amalgams a few years ago. Kathy O'Loughlin, who's the executive director, you've had her on the show. I love Kathy. She was telling the story that she argued against it because she said, you know what, I'm telling you that there's a chunk of this world that needs amalgam. So, if you're in Beverly Hills, you're not doing a lot of amalgams, but if you're in, rural Arkansas, you may be placing a lot of amalgams.
Can I tell you what I saw in Tanzania and Ethiopia? Going to a dental office, they're sitting in a chair. They have a 5-gallon pickle bucket. He drills the tooth, and then he puts the etch on. She rinses with a Dixie cup, and she spits in the bucket. Then he paints the resin on and cures it, and then she rinses with a Dixie cup, spits in the bucket. Then he puts the composite on, cures it, and then goes to polish it for like a half an hour. And is just amazed at how beautiful it works. And I'm just standing there. I don't know whether to laugh or cry.
Yeah,
But the thing I don't get though is, the fear. When you tell someone they need dentistry, they only have 2 questions. They never say, I want it in the same day. They say, how much is it going to cost? I don't get paid till Friday, insurance. Or is it going to hurt? Are you going to give me a shot? Are you going to knock me out? If I ask any 10-year-old boy, hey boy, it's on your molar. If I go metal, you won't replace it again until you're as old as me. If I go tooth colored, make it fancy and pretty and whatever, you'll replace it every 5 years. What do you want? 100% of boys say, I don't ever want to do this again.
I don't want to do it again. I'm a dentist.
I don't get it. But go ahead.
I had a funny story. I had a composite done. And look, I'm not bad-mouthing because I do composites. I had a composite on my premolar. It was done in the Esthetic clinic. I used to run the Esthetic clinic here. So one of the faculty put a composite in. 5 years later, I'm getting a radiograph. What do I have at the cervical margin? Recurrent caries. And so I go back to a different member of the faculty, and I said, guys, can you take this out? I got a cavity. And a couple other residents in the Aesthetic program are watching. He drills out, and then he's getting the composite, and he'll put an amalgam in. And he goes, amalgam? He goes, what are you talking about? I said, I had a composite. Prior to that composite, that amalgam that was in there originally had lasted 20 years or more. I had a composite that lasted 5 years, put an amalgam in. That was 15 years ago. I still got that amalgam on that tooth. So love or hate it, do them or don't do them. If you badmouth amalgams, now the mercury issue, you can argue that. That's a different issue. I don't see a lot of evidence, but they're not a bad restoration, please. And like you said, I don't want to be having my teeth filled every 5, 6 years.
Well, you went to the MIT Sloan School of Business. I mean, if you've already decided to accept a 40% lower fee,
right,
and then these bonding agents, I mean, in my lifetime, a barrel oil has fluctuated between $20 and $100 a barrel. Yet
right,
the bonding agents have never gone under $1 million a barrel. I mean, can you name a bonding agent where you give me the price that I buy it through Patterson, Shine, Benco, Burkhart, and figure out the milliliters to a barrel of oil? Can you name one bonding agent that costs less than $1 million a barrel?
I got to tell you, and it's crazy when you look at the chemistry in bonding agents. To be quite frank, I mean, we're not talking rocket science here. I mean, the chemistry of a bonding agent is not nothing in that bonding agent should make it that expensive. Let's face it. So you're right. No, it's crazy. And even that, you wet, people take their bonding agent, they wet their instrument with it, you know. So now you're dripping your bonding agent on your glove. You just drip. How much does that cost you to wet your instrument? You spent $30-$40 to wet the instrument. I agree with you. Amalgams, cost-wise, are double the lifespan. So you do the average cost of an amalgam per year. So my amalgam probably cost me a penny a year at this point, a couple of these, because they've been in my mouth that long. But again, dentists don't think that way. They're doing white fillings mostly because when you say to a patient in Back Bay, Boston, you have a choice, silver or white. They look at you because they obviously don't know the science, they don't know the literature. Well, of course, white. What's interesting is when they ask dentists which lasts longer, most dentists say they're the same. And I always say to a dentist, if you're telling them that, then you really are kind of lying to them a little bit here, because you're not giving them the facts. You know, you're making it up.
Well, I think they're gonna start seeing it differently, because in 2005, the average dentist income, according to Marco at the ADA, was $219,000 a year, and it's gone down every year since, and now it's down to $174,000. So they've lost $38,000 a year income in the last decade, primarily from signing up onto all these PPOs, which is on average a 40% reduction in fee. So if you're going to continue to say, if you're Delta Airlines and want to do composites when you're getting your lunch eaten by Southwest Airlines, eventually you're going to say, you know what, we don't give away free meals anymore. I mean, when I started flying in Phoenix to lecture, America West gave free drinks.
Well, you know what some of the insurance companies are doing? You know more than I do about this. It used to be that for the crowns I was getting reimbursed for, I had to accept their fee. So let's say you're getting, we'll make it simple. You're getting $1,000 a crown, which would be pretty inexpensive. And they're giving me $700. All right. Now what some of them have been saying they want to do, or they're doing it, is if you sign up as a provider, you have to give the same fee for all the crowns you do. So now if I'm doing 10 units of crown and bridge, I'm losing 30% of my income, which means instead of getting $10,000, I'm getting $7,000 for those 10 crowns. That's a huge hit. And you start doing that, and that's pretty conservative. Some of them are taking away more than 30%. I agree with you. It's crazy. If they start doing that, saying that I've got to accept their fee if I take their patients for any procedure I do on that patient, how can dentistry accept this? It's crazy.
They're actually, the dentists are just waking up to what they did several years ago. They didn't even know almost every dentist, the average dentist is taking 8 to 12 PPO plans. When they get the contract, they never read it or have a lawyer look it over. They accept it like they do on your iPhone when it says, do you want the iPhone update? You just hit accept, and you didn't read the contract. And a lot of these contracts they signed said that they can enroll them into Medicare and Medicaid.
Yes.
And then if they want to get out, they have to send a written letter and give them a 1-year notice. Some of them are getting a 2-year notice. And they're sitting there saying, what the heck? Is like, dude, you signed a contract. You're a doctor. You didn't even read the contract. And the ADA has a free service where you send them the contract, and all you got to do is tell them which one it is, and they'll send you a whole analysis of the contract. And they got like 6 full-time attorneys, and no one ever uses it.
But look at these young dentists. A lot of them don't join the ADA. They don't take advantage. I mean, I think, look, I'm a member of the ADA, and I think if you take advantage of things like that, the ADA, their website with their evidence-based dentistry website, the ADA allowing you to send those to be reviewed. But I think one of the things your young listeners, I was at the ADA meeting, the complaint the ADA has, I lectured at the ADA meeting, we're not getting the young dentists to sign up. And plus, corporate dentistry has taken over a lot of education. So what's happening now is, if you're working for a corporate dental group, they give you your education, so you don't go to the ADA anymore. So again, things are changing. And I think they got to listen. I mean, somebody like you're the expert in that area. I mean, that little bit of advice you just gave some young dentists could save them a ton of money if they listen to you and pay attention.
Well, one thing, and I'll leave on this because I know I'm being greedy with you, but one difference with the millennials is, we came out with Dental Town in 1998. It's got 250,000 members, and then we came out with the app in 2008. But we put up 360 courses, including one for you. They've been viewed over 650,000 times.
Wow.
And millennials, they just say, why do I want to fly to another city? Why do I want to get in my car and drive down the convention center? I'd rather lay in my bed and prop my iPad against the pillow, and then I don't have to take notes because then I can just watch it again. And on that note, I would do anything to get another course from you.
Oh, I'd love to. We'll offline. We'll talk about it. It would be great. And yeah. I mean, you guys are great, and I have a lot of respect for what you've done. I mean, I met you when you were a baby too. We were at a conference in Florida. I don't know if you remember, a long time ago.
I think you met me 50 pounds ago. And
20 pounds ago on my end. Hey, we're doing all right. Trust me, we're holding our own.
Yeah, I always love you lecturing. I saw you lecture in Florida. I've seen you lecture at Ivaclair groups. I think I met you once with so many. But you're an amazing man. Thank you for all that you've done for dentistry, and thank you so much for coming on my show.
Thanks, Howard. Anytime you want me, I'll be on.
Okay, well, hey, if you ever have something you want to talk about, you just email me back and say, I want to come back on and do another show, because we'd love to have you.